Hi, good morning. Good afternoon for some. I am here in Israel, in Safed, in the hospital of Safed. I am Alejandro Roisentul. I am an oral maxillofacial surgeon. I am here in Israel for 30 years. I study my dental school in Buenos Aires, Argentina, in the University of Buenos Aires. And I did my residency program in Israel, in the north of Israel, and part of in the Queen Victoria Hospital in England. Now I am here with my mask. As anyone here in the world, in Israel, we still in some kind of quarantine, but. We are using these days for being in contact with people. We listen to lectures from all around the world instead of going and meeting with all these international meetings. I have been the president of the Israel Association of Maxillofacial Surgery. I am active member of the International Association of Maxillofacial Surgery. So we have next year the Glasgow meeting 2021, and we hopefully be meeting together and have a good cup of wine. And today I prepare a lecture about bone grafts to see how we can use it for dental implantology, to prepare our mandibles and our maxillas to receive our dental implants. I will answer the questions if you have. You can answer the questions in the chat. You can ask the questions in the chat. I'm not going to answer during the lecture. I'm going to answer all the questions at the end of the lecture. So I hope you enjoy this lecture, and we can talk at the end of it. So I am Dr. Alejandro Roisentul, and this talk is about the use of bone graft in implantology. I'm going to give a short review and show some clinical cases. Before we start, we are now in the peculiar situation, and I'm going to talk briefly about some reflections during Corona times. What have we learned? We learned that the curve must be flattened. We learned that the size of the virus is 60 to 140 nanometers. We learned that there are N95 respirators, and they call like that because they filtered 95% of the particles. We have learned there are two drugs, chloroquine and hydroxychloroquine, that it was used in 1947 for malaria, and now comes back, and they are using it for the COVID-19. And some papers say that it's very helpful, and some that not. That my privacy is public, then we should sneeze at the elbow. That in 1500 before Christ, we had 10 plagues in Egypt. In 14th century, we had the Black Plague that kills between 75 to 200 million people during the term of 10 years. That it was for the fourth of Eurasia population. In 1918, we had the Spanish flu that killed about 50 million people only in 1 year. it was 2.5% of the world population. And now in the 2019, we had the COVID-19. But only in 2 weeks, we have the genome sequence, and we had the valid identification test, and more than 500 proved clinical trials. About the health workers, about us. Most of the people of the world look at us like we are heroes, but I think more I see us like this child, because we came to this world to cure, and that's it. Let's talk about bone grafts. What we expect from the ideal bone grafting. It should have the combination of osteogenic, osteoconductive, and osteoinductive properties. Should have high rates of incorporation, insignificant resorption and minimal morbidity. Should provide reliable and proven long-term success rates, and be cost-effective. Allow for the sufficient bulk of bone to be regenerated. Permit the placement of dental implants within the healed graft with high success rate. Bone graft physiology. What is osteogenesis? Osteogenesis occurs when surviving osteoprogenitor cells within the grafted material differentiate into osteoblasts and form new bone within the recipient site. Osteoconduction occurs when grafted material functions as scaffold for the ingrowth of vascular tissue and mesenchymal cells from the recipient site. Osteoinduction involves new bone formation through the recruitment and stimulation of recipient site osteoprogenital cells using bone growth factors transplanted within the grafted material. So we have the bone graft types that are autograft, allografts, alloplastics or synthetics, and the xenograft. The autografts are from the same individual and have a genetic match. They are the gold standard, and this is because they have the three mechanisms of bone healing: osteogenesis, osteoconduction, and osteoinduction. The advantages are osteogenic potential, they are affordable, and we can have also cancellous or cortical bone. The disadvantages are that we have a donor site morbidity, we have prolonged operating time, and the lower patient acceptance rates. Sometimes our patient don't want to have another site to take bone, so they prefer to have stock bone from the bottle. The allografts, they are from the same species, and thus they are genetically different. They are osteoconductive. Some claims that they have some osteoinduction properties. The advantages are lack of donor site morbidity, shortened operating times, numerous configuration of grafting mediums. We can have it in gel, in blocks, in particles, in small particles, big particles, whatever, a lot of forms. The disadvantages are that we have no osteoprogenitor cells, and we have a lack of considerable osteoinductive capability, if any. Xenografts, they are derived from the inorganic portion of bone from a different species, like a bovine or porcine. And we have osteoconduction only, and again, the same advantage and disadvantages. Also, the alloplastic have the same advantage and disadvantages. And we have non-biological materials like hydroapatite, calcium sulfate, and bioactive glasses. And again, we have only osteoconduction. Let's see the cortical versus cancellous bone issue. The cortical bone heals by a process referred to as creeping substitution. The graft undergoes resorption with simultaneous replacement with viable bone. Revascularization of the cortical graft begins at the periphery of the block graft and slowly proceeds towards the interior of the graft. The advantages: we have high concentration of BMPs, we have a dense segment of bone that is amenable to rigid fixation to the recipient site, initially primary graft stability, that is very important, development of the D1 to cortical D2 bone within the recipient site. Disadvantages: reduces osteogenic activity, high failure rate with yearly exposure, and we know that as clinicians that sometimes when we put this block and we get exposure that anything fail and we have to do it again. The need to contour the block graft to passively fit the recipient site. We're going to see it later. Slow rates of revascularization and incomplete bone replacement. The particulate bone has high concentration of osteocompetent cells derived from the trabecular endosteum and cellular marrow, healed via a process referred to as rapid incorporation. It has rapid revascularization because the large trabecular spaces within the cancellous graft, and we have an increased osteogenesis compared with cortical grafts. The advantages of the particular bone: cancellous graft possess more osteogenic activity, allow more rapid and complete revascularization, are ultimately completely replaced with new bone within weeks to months. But the disadvantages of this bone are the inability to rigidly fixate the grafted material, frequent need for membranes or titanium mesh, lack of initial mechanical stability, and the lack of immediate structural support. Let's see about autologous bone graft. The sites to take bone, the donor sites, for the alveolar bone graft are the ramus of the mandible, the symphysis, the iliac crest, the calvaria bone, and the tibia. Let's talk about the bone graft from the symphysis. It's the mandibular region between both mental foramen. We can take bone 2 to 5 millimeters below the apex of the anterior teeth. We can take monocortical bone block. We can obtain cortical bone, some medular bone sometimes, and we have a bone type D1 and D2. We have 1.5 millimeter of thick cortex. We can obtain a bone block of approximately 1.5 to 6 centimeters from the midline, or two cortical cancellous block of 1.5 to 3 centimeters from each side of the midline. Or we can take with the trephine with the 8 millimeters diameter. The advantages taking a bone graft from the symphysis are low morbidity in the vicinity of the receiving area, no need of general anesthesia. The origin of the bone is intramembranous bone, so we're going to have much less resorption from other sites. It's osteoinductor. That means that we have autologous bone with a great amount of bone morphogenic protein, a BMP. we have a comfortable surgical approach, and we can use in block or ground it. The disadvantages are limited bone volume, can cause altered sensation of the anterior teeth, and we can have some altered sensation of the chin and lower lip. The contraindications of taking bone from the symphysis are anterior mandible with a vertical height of less than 1.5 centimeters, previous genioplasty, pathologic abnormality like dental infection, cyst, or tumor, or metabolic bone disease. Let's see a case that we need. We need a bone graft from the iliac crest, from the symphysis. So we have here a need for put a bone graft here at the left side of the mandible. So we're going to take bone here from the symphysis. So I'm going to do a flap, not taking these papillas that are very important to keep them. So I'm going to do an incision here and reflect the flap, the mucoperiosteal flap. Also, we have the donor side and the recipient side. Here you can see the nerve, the mandibular nerve, the mental nerve, coming out of the mandible. So we have in the same place the donor side and the recipient side, so we don't have to go to other places. So this is the region that I'm going to take, and I prepare the recipient side here with these holes that you saw before. That this is very important to have this osseointegration with this block. So I took this block from here, from the symphysis, and put here to the recipient side. I must do a good fixation with titanium screws, and I can switch up again very, very nicely with resorbable sutures that I used to use. So if you wait about 4 months, you see these screws are not taken out yet, and you see some resorption of the bone also here. So these are some disadvantages of taking this block, or many other techniques. So we have to take in account that we can have some resorption. So, but it's quite nicely. So we take out these screws and we put implants, we put rehabilitate, and that's it. Inferior anterior region. Normally we think about the inferior anterior region as a non-static region, but sometimes when the patients come like that and they smile, so they show these lower teeth, and it becomes, for me, a static region as well. In these cases, these tooth has to come out because of periodontal problems. And when we do the CT scan, the CBCT, we see that this bone is very, very narrow. So maybe we will need a bone graft. And after taking out this tooth, we see that instead of one tooth, we will need a 2 teeth restoration. But the room here is only for 1 implant. So what we're going to do is, what we normally do is put in only 1 implant and restore these 2 anterior lower teeth. So we reflect the mucoperiosteal flap, and we see the region. So the easiest way to resolve this is taking bone from this symphysis again, because we are very close in the same place that the donor and recipient side. So I'm going to take a piezoelectric surgery that is very, very nice. It take bone very nicely, very clean. So this is the bone graft that we are going to take into here. Okay. So in the local anesthesia, the same place for the donor and recipient sides, we take a nice block of bone, again taking into account this 2 to 5 millimeters apical to the teeth, not to cut the apex of the teeth. The mental nerve, we may exposure the mental nerve to see it during the surgery, not to damage it. And we can take this nicely amount of bone. So here I'm taking a chisel, a bone chisel. We take a very nicely a block of bone, and this is like, it looks like, this is the cortex, and this is the membranous, the cancellous bone here. Not much, but it's good. It's quite good. We can take, after we take from here, we can take again here some particles of cancellous bone to fill the gaps. So here's the case. This is the fixation of the blocks. We have to adapt very, 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 very well. If this is not adapted well, it's not going to integrate. So we have to work on this, sometimes quite a lot of time to achieve this adaptation. Should be perfect. Other thing that we can do is filling a little gaps with the bone that we take from here, from the cancellous bone from the chin. And we wait for months, and the bone looks like that, very nice. So we can put the implants, or the implant, like in this case, one implant, and we can finish very nicely like that. This one implant with these two anterior teeth. Mandibular ramus bone grafting. We can obtain monocortical bone block from the inferior retromolar region and ascending ramus of the mandible. We obtain 110th cortical bone D1. The traditional ramus graft yields of cortical block measuring 30 millimeters in vertical by 30 millimeters in length. The cortical thickness of the ascending ramus graft varies from 1 to 2.5 millimeters. The best surface to volume ratio we can obtain with this type of graft compared to the chin or any other place on the oral cavity. The best surface to volume ratio. And we can rehabilitate 3 to 4 dental units. The advantages are low morbidity in the vicinity of the receiving area. We don't need a GA, a general anesthesia. The origin of the bone is intramembranous bone, so we have a less resorption. It's osteoinductor, so we can obtain this is a bone, autologous bone with a great amount of BMP. We have a comfortable surgical approach, and can we use in block or grounded. The disadvantages, we have a limited bone volume. We have a risk of mandibular nerve damage. This is sensorial, or more rare and not frequently is mandibular fracture. This is an example of taking bone from the ramus with the piezoelectric surgery. This is the ramus exposed, just beneath the last tooth. So we took the piezoelectric surgery on the external oblique line. And one of the big advantages of taking bone with the piezoelectric surgery is that these ends are bended, so we can go down here and do this cut of the lower part of the bone cut very easily. That is very difficult doing by other methods. So we have here the chisel. So we use the chisel, the hammer. So we took out this nice piece of bone block. Another example is using the ramus like as a donor site. So we have the same donor and recipient site. Here exposures of the donor site. and very easily in the same flap, in the back of the flap, we can take a little piece of a bone from the ramus and taking this cortical bone. And again, it's very important to do these holes to have this blood coming out. That going to assure that this bone block is going to integrate to the mandible. So we have to take time to integrate this block that we put in two screws, titanium screws, adapting very well. Here, as you see, there's a little gap we should fill with xenograph. This is going to slow our resorption rate of this block. That is quite important to do that always when you use these blocks. So it's going to again to slow the resorption of this block. Other cases of an anterior tooth that we have to take out because of the big periapical lesion. So we take it out, we do the CBCT scan, and when you do the CBCT scan, so we can see that we have a very big lesion, loss of bone. So here we plan again. This is the case. They are the cases that I usually do these blocks when have a lot of bone missing. And again, we open the flap, mucoperiosteal flap, and as you can see here a lack of bone as the palatal region. So this is very important because when we do not have this palatal bone, we are in troubles. And we see here this little bridge of bone that is very important to keep. Do not take this bone, even if it's very small, because it's going to, in some point, keep our height of this region of the buccal plate. So we take again bone very easily from the ramus. And we put a little piece of cortical bone at the palatal side to contain all the bone that we're going to put here. And we put a xenograft. We fill all it from with xenograft. We have this buccal bridge, which is palatal bridge. So we see it after 6 months and look quite nice. And it allows me to put an implant. This is how it looks at the extraction, no bone at all. This is the block with the GBR, and this is the end situation. So this is the patient smiling after having all these months of surgeries, but very happy. This other case, with extreme case, with this bone loss and soft tissue loss. That in these cases I did in the past GBR it was failed, as you can see. I did an immediate extraction and immediate bone graft with GBR. Everything's failed, so we have this bad situation. So I decided again to make a bone block. And again, I took bone from the ramus of the mandible, and here we have a nice block, well adapted with 2 fixation screws. We fill it everything with xenograft again to slow the resorption of this block until we put the membrane, and we wait another 4 to 6 months, and we open up again. And we have a nice bone, so we can put our implant and finish the case like that. This is before, this is the time of the restoration, and this is the final restoration. We can see a nice piece, nice bone, integration of the bone of the implant. The final restoration is not bad if we compare how we started. The iliac bone grafting, the origin of the bone is endochondral, and in contrast of the other sites that we took, bones and symphysis, or the ramus that are intramembranous, the same origin of the mandible. Here, the different origin of the bone, so it's going to have some consequences because this bone is going to resorb much more and much rapidly. The advantages are higher concentration of osteogenic cells compared with other sites, can be obtained cortical and cancellous bone. The iliac rest contains 50 milliliters of particulate cancellous bone, or one block of cortical cancellous bone up to 2 by 6 centimeters, an average 13.5 centimeters. The disadvantages are need for hospital environment and general anesthesia, the need of a second surgical team and additional surgical site. And we can lose, as we said, up to 40% of the volume in only 1 year. This is because the origin is endochondral and not the same of the facial bones. Here is a case of extreme mandibular resorption. As you can see, in both sides, we don't have alveolar bone over the mandibular canal, as we can see here. It's a young patient. She is not 20 like that. She was very young, so it was before getting married, so we would need to have some rehabilitation. So we decided to take bone from the hip, and this is during the surgery. Look at the bone, the large quantity of bone that we could take at this time. So we need to put this block on both sides of the mandible. Is in GA in the hospital under general anesthesia, as I said, but it was maybe the only thing that we could do for her. So we did that. We waited about 6 months, and we did a virtual planning for this case, and we decided to put short and wide implants, as you see here. But most of the important things that I should notice that we have here a wide mandible, but the bone is D3, mainly D3. It's not a nice bone that if we compare to the D1 here in the mandible, and here we have D3, maybe D4, I may say. So the quality of the bone is not perfect. But here we are. We plan to put 2 implants on each side, and this is at the time of the surgery and the local anesthesia. You see the nice bone here, and we took a short implant, a 5 or 6 millimeters long and wide, and we can put these 4 implants. This is the X-ray. This implant come out after 4 months, so we did it again, and we finished the case. Let's see some clinical cases with guide bone regeneration or autologous bone grafting. Here we have a difficult case, because one side we have these tooths, the 11, 12, and 13 that we have to take out. And we leave these teeth in place, normal teeth and healthy teeth. So at the time of extraction, I decided to do an immediate bone grafting with biphasic calcium sulfate, just to keep the volume of the soft tissue and hard tissues. I put 2 implants on the place of 11 and 13, and we close everything, and these are the implants, and this is the situation 2 weeks after that. You look at quite nice this soft tissue is. The volume contained into this biphasic calcium sulfate and the implants. 4 months later, we have the second stage, and it looks like that. And one of my recommendation is at this stage is to do a provisional bridge and not go directly to the definitive one, because we have to see, to evaluate again what happened with the provisional from a aesthetical point of view. So here we have the provisional bridge. So we take, if you look at this case, it looks nice with the provisional bridge, but the height of the teeth, the remaining teeth, the soft tissue are lower than the soft tissue that we have at the right side of the provisional bridge. So we're gonna do a crown lengthening and bleaching of the teeth, and we're gonna end up with these results that are quite acceptable. And so we start at the left here with this bridge, and we finish after the crown lengthenings and bleaching with this nice situation of the bridge into the mouth. Let's see another example of single tooth rehabilitation in 2 stages. Again, we did here GBR, a guide bone rehabilitation. So we did here this. We put an implant after the GBR, and here the situation, because we did here these cases in 2 stages. Why I did that? Because the first time I took out the tooth and put this implant with the GBR, and I wanted more soft tissue to have it here, to use it later at the second stage. Here's the second stage surgery. So we open up the flap, the mucopurusal flap. I expose the implant, and I have here a post that I'm going to put here. And I want to show you here the situation that we have all this soft tissue that is going to give us this volume that we need for the aesthetic reasons. If you see here, I took the incision. The situation here that I take the incision from the palate, so we have more soft tissue on the buccal place. So when after done this, so I have this provisional that I should adapt very well, and here we have the neck of the post that I should respect, and not construct this anterior provisional too high. So I have to respect the biological space that is about 2 or 3 millimeters. So this bone is not going to resorb. And this is the final situation. This is the lady, the young lady, with a nice smile, nice results, and a nice bulk of soft tissues because the technique I used. Lateral agenesis. Have a boy like it was at his 13 with the agenesis of the laterals, the upper laterals teeth. So we did the panoramic X-ray, and we send this patient to orthodontics treatment to open the space for the laterals. And meanwhile, we did a CBCT scan, and we could see that we have a lack of buccal bone, although we have a nice length of the crestal bone, but no bone. And this is something that we see mainly in the cases of agenesis of teeth, that we don't have the development of the buccal plate, and normally we see this kind of resorption of the buccal plate, or no development of this buccal plate because the lack of the teeth here. In this case, I decide to use Allogeneic bone graft, a DFDBA, a Demineralised freeze-dry bone, and look at this mandible. The place is very, very narrow, and we took this block of DFDBA that I bought in. And I should adapt it very well. This looks like that. Just after I open the box, I just check the way it sits, and I have to take a piezoelectric, or like this case, to adapt the block. And the block again should be very, very well adapted. Any gap is going to end up with the failure of the block, and so I do this fixation with the titanium screw, and again also we use a xenograft to reduce the resorption rate of this block, and I cover it with the collagen resorbable membrane. This is at the right side. At the left, again, another block, and with the xenograph, and adapted very well with a membrane, a resorbable collagen membrane. We wait about 6 months. We open up, and we are ready to put our implants. In this case, we did freehand, no virtual. So it's quite difficult to put because we have this root of the canine on the central, so we have to take some X-rays during the surgery, seeing that we are not damage the root. Here at the right side, inserting my implant, taking the X-ray at the end, seeing that this is in the correct place. And this is the next implant at the left side. Is a 3.3 narrow implant that I put in place. This is the X-ray after inserting the implant. And again, I did a provisional post. And here the provisional restoration. I keep this restoration for at least 6 months because I need this soft tissue maturation before I take an impression for the definitive restoration. These are the impression posts, the transfers, and we use the prefabricated 3.3 angle post, and these are the final restorations of the laterals. Here the final photograph of the restoration. The soft tissues are maturating, the implants in place, and we have a quite nice result. This case I follow him for now 24 years because he's my son. So we have a long follow-up, and he's okay, he's right. A similar case, but done by virtual planning. Again, is much more easier to take a virtual impression at the clinic and sending this file, STL file, to the company, asking to make a surgical wafer like that, as you can see. So on the company, they can put in the software and see again the situation here. We can see a block that this lady she had before, a block graft from the chin. Here the situation, and here we can see the blocks. So we can have this surgical wafer after a few days. So we can do a quite easy surgery, putting the implants on place very, very safely, and not damaging the roots and any other anatomic structures. And I think nowadays I should do these cases only with virtual planning. Let's talk about the platelet-rich fibrin, PRF. It's a second generation of platelet concentrate, and it's a leukocyte and platelet-rich fibrin biomaterial. The platelet-rich fibrin is obtained simply by centrifugation without anticoagulants and is therefore strictly autologous. It's a low-cost method. The PRF stimulates tissue healing by significantly increasing the recruitment and proliferation of variety of cells, including endothelial cells, gingival fibroblasts, chondrocytes, and osteoblasts. It promoting tissue repair and angiogenesis. These processes are regulated by local concentration of cytokines and growth factors trapped within the fibrous scaffolding. So we can prepare here CGF membrane and sticky bone. The CGF or concentrated growth factors, we are going to use it for making our membrane, and the AFG, our autologous fibrin glue, to make our sticky bone. We take 20 to 60 cc of patient's venous blood from the forearm. The blood is divided to 1 to 2 non-coated vacuum containers to obtain autologous fibrin glue AFG, which will make our sticky bone, and 2 to 7 glass-coated test tubes without anticoagulants to obtain our CGF. The blood in the test tube is centrifuged at 2,400 to 2,700 RPM. But there are some other protocols nowadays, so you have to look which one you like using this as a centrifuge. So we have the non-coated tube show 2 different layers. The upper layers is autologous fibrin glue, AFG. The lower one is red blood cells that are collected in the bottom layer, which will be discarded. The other tube, the silica-coated tube, shows 3 different layers. The most upper layer is platelet pore plasma that we don't need. The middle layer is fibrin buffy coat layer, represented by a large and dense polymerized fibrin block containing the concentrated growth factors that we should need. And the bottom layer is again the red blood cell layer that we discard. So we have the CGF, concentrated growth factor. We take it and compress with a metal cover, like you see here. Here you see at the first time we took it from here. And it looks like that. It's very dense, so we just compress with the cover of the box, so we can obtain this kind of membrane, this CGF membrane. And the upper AFG autologous fibrin glue is mixed with the particle autologous allogen bone. So we took the allogen bone particles. You wait about 20 minutes and you get like that. And it's very dense and it calls sticky bone. So we got a short video showing how we take the blood. So we centrifugate. We have these 2 vacuum containers. We use the upper one to mix with the allogen bone. The next one we have this membrane. It looks like that. So we add here the allogen bone. I used to do this technique before I start the surgery. So I do everything. I put the allogen bone and I start my surgery. So I have this 20 to 30 minutes I have to wait to have this sticky bone. So everything is ready. Now I can cut and put in place. It looks like that. So it's very nice technique. It's very easy. It's very cheap, and it looks quite good. Let's see a couple of cases to finish this lecture about rehabilitating an anterior tooth with a single unit technique developed by the Paltop company. And this is the case with the tooth that have to come out, obviously, and this is the CBCT. In this case, I use a guide bone regeneration because I have this bone plate almost intact, so I don't need here a block. I put a xenograft, I cover with a membrane, and I wait for the next step. You can see here the post-op that have a nice bone formed after the GBR. And I use here a single unit base. This is this place. I put the base that is going to stay here forever. This is the final base for the final restoration. I use a post, a temporary post, prefabricated, and I took a stock crown and I adapted it into the mouth with the acrylic. I take it out and I adapt it very well in my office. And here I use the screw. We have a screw retained anterior tooth that I made in my office. And this is the final restoration. Using the same base is going to stay here. It's the same base I used at the beginning. And this is the upper tooth restored. But nowadays, I used to use this technique. Full guided is much easier, fast to do it in my clinic. I just take an impression, send to the company, and they can make my wafer and everything. Here, in this case, for example, with a young lady, when she came to my office like that, with a missing tooth, and I took an impression, a combined CT, I sent to the company, and they did the evaluation together with me, and we see that we have a high level of the alveolar bone here. So we have here other problems like the palatal nerve. This is very difficult to avoid without virtual planning because I don't see it during the surgery. We have the bone notch, and we have again this height of the bone that we have to have some solution for it. So we decide to use a conical connection implant, a PCA from Paltop, and again we have the planification of the case. This is very important to notice that the planification are either prosthetic and surgical driven. It's not only surgical. We plan the position of the implant regarding the bone, regarding the nerves, regarding the other roots, but also the prosthetic part is prosthetic driven. I can decide where the implant is coming out. So in this case, it's a screwdriver tooth. So I plan at the beginning before I start. Now I have this surgical wafer that's coming to my office together with this tree model with the temporal restoration. So we have here the base of the multi-unit, the post already done by my lab, and I have this provisional also done by my lab. So the patient, when they come to the surgery, everything is just ready to to use. I don't have to waste time adapting and doing things blindly. This is the case. I open a mucoporistal flap. I put my wafer. I have to say that I could do this case without raising a flap, but I always erase a flap to see what happened with my bone. I don't rely 100% on the CBCT. I want to see the bone. I'm a surgeon, but I recommend almost always to raise a flap, even a small flap, to see what happened underneath your soft tissue. You should see your bone. I always open a flap. This is the way I recommend to work, even if you are sure that everything is okay and you have your wafer. So now is the time to put the implant. This is the conical implant. This is the wafer, putting the implant on place with all the system. This Paltop 3D system. And here is the implant in place. Here I put the base of the multi-unit, the post, and my temporal tooth. Here a suture everything up, and this is at the time of the surgery, the emergence of the screw from the palatal side as we planned. And here we can see this conical connection and the conical post. You can very nice, and everything in place. And this is 3 months later with the provisional. We stuck to this coronavirus situation, so we couldn't keep going to the final restoration. So next time we can see what happened next. My epilogue. You should be familiar with the techniques and materials available. The handling of bone graft requires high level of precision. Try to use the simplest technique available to reduce complications, and try to use virtual planning if possible. Thank you very much for your attention. Here is my email and the ways to contact me by Facebook, Instagram, whatever we have today. Everything is fun, and we hope that you enjoy this lecture. And we see you later after our Corona time. Bye. Hi. I hope you enjoy the lecture and clarify some point of using the bone graft. I have some questions that I'm going to answer now. We have Robert Teague from Ariston Dental, UK. The first question is, he said that in orthopedics, the use of silicate substitute calcium phosphate is documented to deliver inductive cell process similar to allograft. Well, there's some, as I said in my lecture, there are some substitutes, synthetics and allograft, that they claim to have some inductive process. So I agree, this is okay. We don't know how much induction these substitutes have, but they have some properties that we may try, and if we are happy, sometimes they work. Another question is to reduce allograft block resorption. You show the xenograft covering. Could a very slow resorptive synthetic hydroxapatite be achieved? Same protection to avoid use of animal tissue. That's okay. You can use any hydroxapatite that you like. If it can be xenografts, can be synthetics, or any other sources of hydroxapatite, that's okay. The point is that the material has to slow this resorption. Doesn't matter where you take it from. Thank you, Robert. Another question from Sabrina. Good morning, and thank you for the talk. My question is regarding the lateral agenesis cases in the 13-year-old boy. At what age did you complete the bone graft? Do you wait until they are close to the end of their facial growth like we do for implants? The answer is yes. Mainly in most of the cases, we wait until the end of the growth, that it's about the age of 17, 18. Meanwhile, the patient is with the orthodontics appliance. In some cases with agenesis in little children, this is well documented. You can put implants as well. But in these cases of lateral, I used to wait until the age of 17, 18. Thank you, Sabrina. Juliana, she asked me what the patient preferred to take a bone from. And it's a nice question, because sometimes it's about how we show the patient. If in the patient that we are going to take a bone from the chin or from the ramus, and it's not it's not a big surgery, and so the patient accepts it very well. If you are confident to doing that and the local anesthesia in your clinic, in your office, that's okay. You can do it. The patient, I think the patients, they prefer with what you advise. If you're very happy doing your GBR with synthetic materials, so the patient is going to be happy with you and accepting your advice. Thank you very much. Michael Kostavakis, a good friend of mine from Cyprus. Why you choose conical connection? What is the purpose? Well, this is a long issue. The conical connection gives us a better switch platform connection, because you are more stable, and so this is documented that you may have more bone over this connection, because it's the pose is going into this connection with the implant, so you will have less bone resorption. That's the reason that we like to use this conical connection for the anterior teeth, mainly for the aesthetic cases. Charlene Bergman from Alpha Omega from New York, a great friend of us. Thank you for the lecture. Much love to all. Thank Charlene, and regards to Richard. Which technique you often use in your private clinic? Private clinic is like taken from the ramus. It's very easy for me to take it, and very easy for the patient as well. Sometimes from the chin it's not too easy for the patient. Sometimes it's better from the back of the mouth. And GBR with allograft xenograph is that they use for me in the clinic. Thank you, Juliana. Sabrina again. In cases of bone grafting in the younger patient, like in this, okay, I think I answered that. Yeah, I answered that. Simon Cohen from Tiberias, very nice presentation. Thank you, Simon. Carla, again, thank you. Interesting. Okay, I think we are done with the questions. About you're going to receive, if you want to see qualification, you're going to have in your mail the questions, and you have to answer it, and you can have the credit. In my last presentation, you could see my mail and how you can connect me anytime. And I hope you enjoyed the lecture, and hope you will see you soon in a meeting, and we can meet each other. Thank you very much. Any questions? My mail is already there. So see you. Bye.